नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we are discussing about the various diseases of the thyroid gland. In the last lecture, we were discussing about thyrotoxicosis, and we have discussed about the etiology of thyrotoxicosis, that is primary, secondary, and thyrotoxicosis without hypothyroidism. We have also discussed about the various clinical features which included the symptoms and signs of thyrotoxicosis. Now in today's lecture, we are going to start with the Graves' disease. Graves' disease is an important disease that is causing thyrotoxicosis, and this is a disease that is asked many times in the examination. So this is basically a favorite topic of the examiner that is being asked in the examinations again and again. So it is a very important topic from the examination point of view. So prepare this carefully. So let's start with the thyrotoxicosis or the Graves' disease. So what is Graves' disease? First of all, let us understand thyrotoxicosis. About thyrotoxicosis, we have discussed in the last lecture that there is an excessive production of the thyroid hormones. So what is Graves' disease? Graves' disease is a part of thyrotoxicosis, and it accounts for around 60 to 80% of the cases of thyrotoxicosis. So out of the 100 cases of thyrotoxicosis, 60 to 80% of the cases of thyrotoxicosis are occurring because of the Graves' disease. Now, the prevalence of Graves' disease varies among the population, and it is reflecting the genetic factors and the iodine intake. So Graves' disease occurs in up to 2% of the women, but it is 1/10 as frequent as men. The age that is most commonly getting affected by Graves' disease is between the age group of 20 to 50 years of age. So Graves' disease, it accounts for around 60 to 80% of the cases of thyrotoxicosis. It is prevalent. The prevalence of thyrotoxicosis varies among the population, and it is reflecting the genetic factors and iodine intake. It occurs in around 2% of the women, but it is 1/10 as frequent as in men. The age group that is most affected is between the age of 20 to 50 years of age. What are the various predisposing factors that are associated with the Graves' disease? In the predisposing factors, we have environmental and genetic factors that will predispose to the development of the Graves' disease. There are various factors which includes the stress. There is smoking, sudden increase in the iodine intake, and postpartum period. So the predisposing factors for development of the Graves' disease includes environmental and genetic factors. We have stress factors. Stress is very common these days, and it is responsible for the development of the Graves' disease. We also have smoking, sudden increase in the iodine uptake. Those certain individuals, if they are taking more iodine, then it is responsible for the development of the Graves' disease, and postpartum period. Many times after delivery, the females are developing Graves' disease. So predisposing factors includes environmental and genetic factor, stress, smoking, sudden increase in the iodine intake, and postpartum period. Now, what is the pathogenesis? Pathogenesis of the Graves' disease. In the pathogenesis, the hyperthyroidism or the Graves' disease, it is caused by thyroid stimulating immunoglobulins, that is TSI. These are synthesized in the thyroid gland as well as the bone marrow and lymph nodes. So the thyroid in hyperthyroidism of the Graves' disease, it is caused by thyroid stimulating immunoglobulins that are synthesized by the thyroid gland as well as the bone marrow and the lymph nodes. In the long term, there is spontaneous autoimmune hypothyroidism that may develop in up to 15% of the patients with Graves' disease. So in the long term, we can see spontaneous autoimmune hypothyroidism that can develop in around 15% of the patients with Graves' disease. Now, in the Graves' disease, we are also having ophthalmopathy, Graves' ophthalmopathy, that is very important. So what is the reason? What is the cause for the development of the ophthalmopathy or the Graves' ophthalmopathy? Cytokinins appear to play a major role in the thyroid-associated ophthalmopathies. So there are various cytokinins that are responsible for the play a very important role in the thyroid-associated ophthalmopathies. There is infiltration of the extraocular muscles by the activated T cells. So in the pathophysiology, there is infiltration of the extraocular muscles by the activated T cells, and they release cytokinins. So the T cells are going in or infiltrating the extraocular muscles of the eyes, and they are releasing cytokinins. And this will result in the fibroblast activation. So there will be activation of the fibroblast and increased synthesis of the glycosaminoglycans. About glycosaminoglycans, we have discussed in this first lecture of this thyroid gland disorders. So what is the function of glycosaminoglycans? They trap water and leading to the development of the myxedema or the muscle swelling. So these are producing non-pitting type of edema. This we have discussed in the first lecture of the thyroid diseases. So what is happening? Cytokinins are playing a major role in development of the Graves' ophthalmopathy. There is extraocular muscle infiltration by the activated T cells, and these releases cytokinins. They result in the fibroblast activation and increased synthesis of the glycosaminoglycans that trap the water, thereby leading to the characteristic muscle swelling. Later in the disease, there is irreversible fibrosis of the muscle that takes place. There is an increase in the intraorbital pressure that can lead to proptosis, diplopia, and optic neuropathies. There are various clinical manifestations of the Graves' disease. So in the ophthalmopathy, it will result into the intraorbital pressure, raised intraorbital pressure. This will lead to the proptosis. Proptosis means drooping of the upper eyelid. Diplopia means double vision, and optic neuropathy means the various neuropathies associated with the optic nerve. Now, what are the clinical manifestations of the Graves' disease? Whenever a patient of Graves' disease is coming to us, what are the clinical features with which the patient can present to us? The clinical presentation depends on the severity of thyrotoxicosis. How much severe the thyrotoxicosis is, means how much excess of the thyroid hormone is being secreted. This will decide the clinical presentation of the patient. So, severity of the thyrotoxicosis, duration of the disease, since how long the disease, from this disease the patient is suffering, that will also decide the clinical presentation and individual susceptibility to excess thyroid hormone and the patient age. So the clinical presentation will depend on the severity of thyrotoxicosis. It will be dependent on the duration, individual susceptibility to the excess thyroid hormone, and the patient age. The more are these factors, the more is the clinical manifestations. There will be apathetic thyrotoxicosis. Apathetic thyrotoxicosis, it occurs in the elderly, and it presents mainly with the fatigue and weight loss. So apathetic, it is usually seen in the elderly patients, and it is associated with two things. We have fatigue and we have weight loss. The thyroid is usually diffuse and enlarged to 2 or 3 times the normal size. So in this condition, the thyroid gland is usually enlarged to 2 to 3 times its normal size. The consistency is firm, but it is nodular. So we will have firm thyroid. The consistency is firm, but it will be nodular, and it is increased 2 to 3 times than its normal size. There will be a thrill or bruit. So the patient, you can observe a thrill or bruit because of the increased blood circulation that can be best detected at the inferolateral margins of the thyroid lobes due to the increased vascularity of the thyroid gland and hyperdynamic circulation. So in the clinical manifestations, the clinical manifestation will depend on the severity of thyrotoxicosis, the duration of thyrotoxicosis, the susceptibility, and patient's age. There will be apathetic thyrotoxicosis that occurs in the elderly, and it is present mainly with fatigue and weight loss. The thyroid is usually diffuse, and it is enlarged to 2 to 3 times the normal size. The consistency is firm, but it is not nodular. There can be a thrill or bruit that can be heard. It can be detected on the inferolateral margins of the thyroid lobes, and it is due to the increased vascularity of the gland and hyperdynamic circulation. So because of it, there will be bruit that will be heard by the stethoscope. Next, we come to the Graves' ophthalmopathy. What is Graves' ophthalmopathy? Ophthalmopathy, we have just understood that there are certain changes in the eyes that are due to the presence of the cytokinins, glycosaminoglycans, that is trapping water. So with the Graves' ophthalmopathy, there is sensation of gritty feeling under the eyes. The eyes are under discomfort and there is excessive tearing. So what is happening in the Graves' ophthalmopathy? There is sensation of grittiness in the eyes with eyes discomfort and excessive tearing. So there is tearing, there is grittiness, there is eye discomfort. The eyes, there will be proptosis, means drooping of the eyes, and it may be corneal exposure. Because of the proptosis, it may cause corneal exposure and damage, especially if the lids fail to close during the sleep. There will be periorbital edema, means swelling around the eyes with scleral injection. Scleral injection means the sclera will become red, and chemosis are also frequent. There will be muscle swelling that results in diplopia. The most serious manifestation is compression of the optic nerve. So the most serious clinical feature or the manifestation of the ophthalmopathy is the compression of the optic nerve. So in the Graves' ophthalmopathy, there will be sensation of grittiness, there will be eye discomfort and excessive tearing. There will be proptosis. Proptosis may cause corneal exposure and damage, especially if the lids fail to close during the sleep. There will also be periorbital edema with scleral injection and chemosis that is also very frequent. The patient will have muscle swelling that results into diplopia, and there will be most serious manifestation. It is the compression of the optic nerve. Now we have non-specs scoring system, NOSPECS, NOSPECS. Now it will represent all the features of to evaluate ophthalmopathy. NOSPECS means 0, that is no sign and symptoms. So N stands for the stage 0 when there is no sign and symptoms. O stands for the stage 1 when only signs are present, which includes lid retraction or the lid lag with no symptoms. S stands for stage 2 that involves the soft tissue involvement and periorbital edema. Stage 2 when there is soft tissue involvement that occurs with periorbital edema. In stage 3, we have proptosis. Proptosis greater than 22 millimeter. Stage 4, there is extraocular muscle movement that is seen with diplopia. Stage 5 consists of the corneal involvement, and stage 6 with the sight loss. So N stand for no sign and symptoms. O stand for only signs. S stand for soft tissue involvement. P stand for proptosis. E stand for extraocular muscle involvement. C stand for corneal involvement, and S stand for the sight loss. So this is the NOSPECS scoring system that is used to evaluate the ophthalmopathy. Now, what is thyrodermopathy? In the thyrodermopathy, there will be pretibial myxedema. Myxedema is because of the involvement of the glycosaminoglycans that absorb water and is responsible for the edema. It is most frequent over the anterior and the lateral aspect of the lower leg. So thyrodermopathy, we have pretibial myxedema that is most frequent and over the anterior and lateral aspect of the lower leg. And the typical lesion, it is non-inflamed indurated plaque with a deep pink or purple color with an orange skin appearance. So what is happening in the thyrodermopathy? We will be having pretibial myxedema. It is a swelling on the anterior and lateral aspect of the leg. The typical lesion, it is non-inflamed and there is indurated plaque with a deep pink or purple color, and it is having an orange skin appearance. The third thing is the thyroid acropatchy. That is the clubbing of the fingers that is seen with less than 1% individual. So with Graves' disease, we can see Graves' ophthalmopathy. There is thyrodermopathy and thyroid acropatchy. What are the various lab investigations that could be done in these cases? In the lab investigation, the TSH level is usually suppressed and the total and unbound thyroid hormone levels are increased. So we are when we are going to observe the lab investigations, we will see that the TSH level is suppressed and the total and unbound thyroid hormone levels are increased. We can also check for the measurement of the TPO antibodies. The diagnosis of the Graves' disease is straightforward. You can just directly see the patient and you can easily diagnose in the patient with biochemically confirmed thyrotoxicosis, diffuse goiter on palpation. There will be ophthalmopathy and often a personal or family history of autoimmune diseases. So for the diagnosis of Graves' disease, we can straightforward do by biochemical mechanism by checking for the TSH level and by diffuse goiter on palpation, ophthalmopathy, and often a personal or family history for autoimmune disorders. The diagnosis is generally established by a radionucleotide, technetium-99, iodine 123 and iodine 131 scan and uptake of the thyroid. Scintigraphy is preferred diagnostic test for the diagnosis of the Graves' disease. So checking for the TSH and unbound, total and unbound thyroid hormone, measurement of the TPO antibodies. We will observe diffuse goiter on palpation of thermopathy and a personal family history of autoimmune disease. The diagnosis is established by radionucleotide technetium 99, iodine 123 and iodine 131 scan and uptake of the thyroid, and scintigraphy is preferred diagnostic test. Now, how to differentiate the case of Graves' disease with other diseases? In the secondary hyperthyroidism, due to the TSH secreting pituitary tumor, there is also a diffuse goiter. And the presence of a non-suppressed TSH level and the finding of a pituitary tumor or on CT or MRI scan can suggest the diagnosis. So we can go for CT or MRI for the diagnosis. The clinical features of thyrotoxicosis can mimic certain aspect of other disorders. The other disorders including the panic mania, the panic attacks, the mania, the pheochromocytoma and weight loss that is associated with malignancy. So there are various disease conditions which can resemble thyrotoxicosis, which includes panic attacks, mania, pheochromocytoma, and the weight loss associated with the malignancy. The disorders, the diagnosis of thyrotoxicosis can be easy, excluded if the TSH and unbound T4 and T3 levels are the normal. So if we have T3, T4, and TSH normals are normal, then we can easily exclude the diagnosis of thyrotoxicosis. The abnormal TSH also excludes the normal TSH also excludes Graves' disease and as a cause of diffuse goiter. So if the TSH is also normal, then it will exclude the Graves' disease as a cause of diffuse goiter. Now, how to treat a case of the Graves' disease or hyperthyroidism? The hyperthyroidism of the Graves' disease is treated by the following methods. Number one, reducing the thyroid hormone synthesis using anti-thyroid drugs. So we can prescribe anti-thyroid drugs to the patient for reducing the thyroid hormone. Secondly, reducing the amount of thyroid tissue with radioiodine I-131 treatment or by thyroidectomy. So there are two methods by which we can treat the hyperthyroidism of the Graves' disease. Number one, by reducing the thyroid hormone synthesis by anti-thyroid drugs. And number two, by reducing the amount of thyroid tissue with radioiodine treatment or by thyroidectomy. So this was all about thyrotoxicosis. In the next lecture, we will be starting with a new topic related to the thyroid disease. So this was all for today. I hope you must have understood the session properly. Now it's your homework to go through the e-notes that I have provided and write the answers to the question that I have given in the e-notes. You also have to go through the book and you have to check for the various topics that I have discussed with you and prepare your notes. So this was all for today. This session is powered by digital version 2.0 JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.